Welcome to the HL7 Vinci Community Roundtable. Today's session is Improving Patient Outcomes Using FHIR, how providers are exchanging clinical data with payers to deliver better quality care. My name is Alex Goss, and it is my pleasure to moderate today's Community Roundtable and to remind all of us that we engage in these forums under HL7's antitrust policies to ensure appropriate collaboration and information sharing. We are grateful for your participation in May's Community Roundtable, Da Vinci's educational webinar. Today's agenda starts with program updates before this month's implementation presentation. This month's implementation story is from FloridaBlue, Healow Insights, and Humana, who share their view of how standardized information sharing improves patient care. The session includes their demonstration of clinical data exchange capabilities, such as point-of-care alerts and up-to-date patient histories, underscoring the value of using FHIR standards to optimize electronic medical record integration to assist in achieving value-based care outcomes. Today's presenters will be Rohit Shinde from Healow Insights, Ranjan Saxena from Humana, Scott Ogden from FloridaBlue, Farheen Khalil from Healow Insights, and be supported by Jaspreet and Ghani for our presentation and question portion of today's event. We've included time to take audience questions after several points in the webinar. Please use the question function in the GoToWebinar panel throughout today's event to submit your questions. So let's dive in. We will post the recording of today's webinar and the program update portion of the slides on Da Vinci's video presentation page on Confluence. Da Vinci's communication lead, Leslie Amorose, will be posting links in the chat box to assist in locating that page and other resources you may find of interest. We've muted lines to aid the recording quality today. Should you encounter audio issues, we suggest rejoining the webinar or obtaining an audio by dialing in using the number provided in your registration. Finally, we do appreciate your survey feedback, and which we will solicit at the end of the webinar. The next Community Roundtable session is June 28th. Please note, there's a little heads up for you here that we will be taking a hiatus in July, but please know that we will have events June 28th and also resume in August. As to our events, there are a few items I'd like to highlight for you this month, including an upcoming presentation at AHIP on prior authorization. For those of you who are attending the AHIP conference in Portland, Oregon in mid-June, Highmark, MCG, and Regions will present their insights on implementing EHR-based authorizations. Also, CMS is holding their usual testing event or Connectathon this July, from the 18th through the 20th from 9 to 5 p.m. each day. This free and virtual event is their 4th annual. We encourage you to join developers, programmers, technology experts, analysts, and CMS colleagues to learn about and test emerging fast healthcare interoperability resources, or FHIR, APIs, and supporting FHIR implementation guides at this year's Connectathon. For a bit more context on participation, I do a shout out for the technology implementers that have leveraged their HL7 FHIR to build a server or application that you are encouraged to bring your implementation to the event, register your endpoints in the Connectathon manager application, and test track scenarios on a live Zoom to share your learnings with other Connectathon participants. For those of you who are healthcare providers and payers using third-party software that plan to attend, you're encouraged to attend and share in the dialogue about how your implementations are going with the goal of connecting you to other organizations trying to solve the same challenges to collect real-world feedback on their FHIR implementations. To advance the FHIR standard and testing efforts, there is an HL7 FHIR Dev Days event just around the corner, June 6th through 9th in Amsterdam. This September, the HL7 FHIR Connectathon and 37th Annual Plenary and Working Group meeting will be held. It's slated for September 9th through the 15th in Phoenix, Arizona, with early bird rates available through August 18th. As some of you may be aware, the Da Vinci Project is expanding its membership with revised 2023 fee structure. Please consider joining if you're interested in creating and implementing standards that enable efficient, value-based care information exchanges. In particular, we are focused on adding the voices and experiences from small and community-based providers, regional Medicaid, and other health plans that are missing from our landscape, as well as missing integration partners, EHRs, platforms, and population health. Please consider this opportunity and contact the Da Vinci PMO to learn more or sign up to get engaged. I'd like to dive into some program updates. As a point of reference, I've included our use case and IG readiness slide. This colorful slide shows the status of implementation guides and their level of maturation. The maturity model blends regulatory alignment, specification status, and real-world adoption. We organize our use cases into 4 categories: foundational assets, clinical data exchange, quality and risk, and the final category of coverage, transparency, and burden reduction. Within these categories are discrete use cases and the radial dials that reflect the current status of the implementation specifications for its current build effort. This is important to understand because the Da Vinci project takes on a use case project with the intent to iteratively advance the specification to a high degree of maturity so they can be handed back for long-term maintenance activities to the HL7 sponsoring work groups. So the radial dials reflect the status of the build that we're currently doing along the continuum of the implementation guide development lifecycle. The process of getting to a use case to the point of being handed off back to the sponsoring work group varies by use case and is expected to take a handful of years to advance from initial discovery of requirements through iterative ballots that advance from an initial specification to a mature or normative specification that is well-formed and has production usage by distinct organizations or countries. The use cases we select within the Da Vinci project are identified and prioritized by our membership. Our appetite for fixing value-based care pain points is balanced by our available resources, whether dollars or in kind. Each year, we review our backlog of use case ideas and solicit ideas for new ones. For example, last year, the membership agreed to add a remittance advice related use case, which we are referring to as the postable remittance, shown as remittance advice on this screen. For a bit of context about this postable remittance advice use case, from a problem statement perspective, when a provider is transitioning electronic health records or is part of a large health organization that uses a different EHR, a single ERA needs to go to multiple destination systems. However, an 835 can only be delivered to one destination system, causing an exception workflow where the provider must manually retrieve the remittance so they can match up the payment and post the payment. The goal with this use case is that the implementation guide that will be produced will support the request for actual adjudication information for all the claims associated with the single payment, the corresponding PLB information, and the 835 batch file from the payers, and return them in near real time to allow timely and accurate posting. So what's the motivation behind all of this? There is an excessive time and effort spent by payer and provider organizations to obtain remits. There are gaps in electronic data interchange transactions that do not cover this use case since an 835 ERA can't be delivered to multiple destinations. Portal access is complex. Provider-facing portals are the main modality used today to manually retrieve missing remits. And it can be very difficult to use portals at scale for this work, and managing access across many portals is challenging. We anticipate automation will present the possibility for a high return on investment that would remove most of the need for human interaction. Our members of this new postable remittance use case are co-leads from Athena Health, Centene, CVS Health, and Change Healthcare and Optum. As part of our normal approaches, once the Da Vinci membership solidifies initial guardrails, including a project scoping statement and a workgroup sponsorship for the use case, will bring it forward for industry collaboration to build out the implementation specification. I'd now like to move on to a few more updates on other use cases. In regards to clinical data exchange, you're probably aware that we published our second version, our standard for trial use, in March, and that has enabled us to move into working on examples to help implementers by creating a CDex example set, and we welcome you to join and bring your experiences to that effort. From a payer data exchange or PDex perspective, we're wrapping up our recent ballot reconciliation and incorporating the updates into the latest build. You can join calls to help with that process as well as get implementer support. From the burden reduction trifecta perspective, the prior authorization support reconciliation of the recent ballot is complete, and the changes are being applied. So we encourage folks to attend those calls to hear the updates and help with the quality assurance or QAing of the guide. Coverage Requirements Discovery, or CRD, and Document Templates and Rules, DTR, has their ballot reconciliation winding down. Few key issues still to be discussed there, and we're targeting publication of these 3 burden reduction implementation guides for July. In regards to patient cost transparency, the phase 2 gathering of requirements is well underway, and you're welcome to join those discussions on Friday at 11. Member Attribution is wrapping up their ballot reconciliation, and they're having calls regularly and seek your participation in the QAing of the modifications to the guide. Risk Adjustment also has gone through its own ballot recently, and they're doing their reconciliation with regular calls on Thursday. In contrast to the use cases that have weekly calls, we have a notifications use case, which is now moved to a quarterly cycle, and will meet on June 7th, September 6th, and December 6th. There is an update planned for the current implementation guide to incorporate implementer feedback. All right, so let's pivot a little bit from use cases to talking about our testing experience and other activities from the Working Group Meeting Plus that just happened a couple weeks ago. The event delivered testing, education, networking, and broadened horizons on many fronts as participants delved into session topics and roll-up-your-sleeve meetings. There was no shortage of opportunities to make a hard choice on what to attend, in addition to productive hallway conversations. There is a link on this slide to the track report out to hear the Connectathon results. I've also included a link to help with demystifying participation with the Learning More and Getting Ready link. Beyond having a basic understanding of what a Connectathon is, it is important to engage in the use case track prep calls to ensure you're ready to maximize the value of your participation in a Connectathon. The Work Group Meeting Plus portion of the week brought an increased policy focus to usual standards development working sessions. The Working Group Meeting Plus showcased within the United States and internationally why policy matters and how standards in all their various forms are essential and interwoven. For example, standards take shape as policy, technical specifications, and business best practices. Policy is needed to define a common understanding of the behavior changes we need to improve the status of healthcare, such as advancing quality and delivery of care, citizen access to care, public health and community well-being, and of course, the data sharing efficiencies and reliability that we're coming to rely upon. Policy and standards development and business implementation adoption have their own unique life cycles, yet are highly interdependent and have touch points to ensure we can advance our goals synergistically. Throughout the Working Group Meeting week, keynotes, accelerator updates, and federal and global initiatives shared their efforts underscoring the idea of policy as a key ingredient that works with other ingredients, FHIR, business, culture, for example, to serve up the human capacity for well-being. It's a great event. Hopefully you'll all attend a future meeting, and they're talking about having a Working Group Meeting Plus in a year from September. The 2023 Da Vinci IG Roadmap provides an overview of the discrete implementation guide work and related ballot cycles and can assist you in your resource planning, whether financial or human, to ensure your organization and teammates have the knowledge, tools, and context to advance interoperable and efficient information exchange as a part of achieving your organization's mission. The top part of the slide gives you the roadmap for the use cases and their ballot cycles. The bottom of the slide provides you with an opportunity to see the various demonstrations and testing opportunities that you can attend. The Da Vinci project has launched an implementation chart for all of industry to use, not just the Da Vinci members. We invite you to share your progress, whether in development, testing, or production, with deploying Da Vinci use case specifications. There are two simple goals for the chart for different audiences. From a Da Vinci project leadership perspective, it will help us develop a picture of the progress of early adopters across our membership. From an industry landscape perspective, it'll help you create clarity on the FHIR community members who are in active development and ready for partners and want to share contacts to a wider community and launching their scalable FHIR solutions. We encourage you to spread the word on your efforts and by adding your implementation efforts, even if they're just in development, testing, and on their way to production, that'll help the community members that are to find you so you can all be ready to connect and exchange data using FHIR. To help you with one-stop shopping, I have a slide here that provides all the use cases and the schedule of when they happen. You can also find easy links on how to sign up the conference call because we center, and also the listservs, since we now have discrete use case listservs to help make your inbox a little less crowded. With that said, I'd like to see if there's any questions that I got in the chat box, and I don't see any. So at this point, I'm going to go ahead. I'll remind all of you that you have the ability to ask questions throughout today's webinar, and I'm going to ask that Rohit Shinde come on screen as our first presenter, while FloridaBlue, Humana, and Healow Insights talk about how they are exchanging clinical data with payers to deliver better quality care in a very scalable way.
Thank you, Alex, and good afternoon, good evening, everybody. Thanks for taking time and joining us today in our experiences that we are sharing about how we are collaborating between the payer and provider to exchange information that can be critical in the quality of care that consumers or members are receiving for value-based care or other care delivery settings. From a content standpoint, we'll talk about how we've started the journey on Da Vinci, why Da Vinci, how is the Da Vinci standards, the IGs that we are all working collaboratively towards helping move the needle and allow us to talk about the same interoperability standards to solve the problems we are seeing with these data use cases. And specifically today, we're going to talk about the PDex, CDex. Can you go to the next slide? So why did we undertake this journey to begin with, right? Many people think, yes, we had HL7 standards. There are other NCPDP standards that are out there. So why did we have to create a new project for solving some of the challenges? And I think when you come towards the payer-provider data exchange, traditionally that exchange has been heavily dependent on claims or financial transactions like ANSI X12 and other methodologies. But as the earth is shifting from fee-for-service to value-based care, there was a real need for providers and payers to exchange clinical information to advance care delivery or improve the quality that payers and providers are collectively trying to get to their members/patients. So few of the challenges in that quest were, yes, payers were traditionally providing data to providers and vice versa, where the clinics, the provider was again submitting information back to the payer, but that information was not collaborated in one data set. So the challenges used to be on the payer side, the data would sit in different silos. On the provider side, where they would need access to this clinical data or the payer information, they would be able to access this through third-party portals or through emails or secure files that the payer is sharing with the provider. And it was a very disruptive workflow. That data would not be available at the right place at the right time. And many a times that would eliminate the right intervention that was required. What this would result in is, again, care not being delivered at the right way, and that would result in poor compliance when it comes to quality scores, when it comes to missed coding opportunities, or whether it's around the star ratings, which again, the quality of care is measured for the payer as well as the participating providers. And then not to forget, a lot of the clinical data reporting related to chart audits or other quality reporting requirements would otherwise be done through traditional methods, which, as we all know from a participating clinic perspective, as well as from the payer perspective, would entail a lot of manpower, a lot of overhead cost and time. So many of these activities would, that's why I have to be limited to once or twice a year, because they were so time consuming and would again take people away from their day-to-day jobs trying to get chart audits or chart pulls done for be it for your quality reporting or star reporting, things like that. So these were some of the challenges that we were facing when we were actively working with our payer and provider partners, and we said to ourselves, there has to be a better methodology to exchange this information. There has to be a better format, because every payer, every provider was maintaining their own standards or having their own format. Somebody was using Excel spreadsheets, others were using third-party portals, and we had to do a better job with that. That's where the Da Vinci project, CMS, HL7 kind of approached and said, yes, the FHIR standards, which are coming up based with the Cures Act rule and 21st Century Cures Act, could be a potential where we can now eliminate all these challenges using FHIR R4 standards. And that's what we have experienced in our journey so far in the last couple of years is, yes, using the FHIR standards, it eliminated the challenge where each health plan, each provider, EHR would otherwise be talking in different formats or custom formats. Now that allows everybody to standardize and communicate using the same language, right? And the good news is it's plug and play, meaning if you are compatible with FHIR resources, then you're able to scale that same FHIR resource for different implementation guides or IGs, as we refer them. So it's not that you're reinventing the wheel for every type of integration or every implementation guide, every use case. If you have already done it, you can reuse it multiple times. But the beauty is that now you can communicate that same framework or use case with multiple sources, be it payer A, payer B, and same with on EMR A versus EMR B. All these FHIR standards are built on robust RESTful API framework, which includes OAuth2 and other industry standard security protocol, where protecting PHI and PII is second in nature. And again, that's the value where traditional point-to-point interfaces that would build between payers and providers would otherwise be less secure or would be questionable, because every integration would follow its own security handshake. So the good news is, using FHIR standards, everybody has the same framework, and it's either OAuth 2 or higher that we are seeing. So from a security and compliance standpoint, it was a great problem solver too. Number three, it eliminated the time it would take all parties to implement, develop, test, deploy these integrations. So if there is clinical data exchange we are trying to build, where data is coming from the payer to the provider and vice versa, from the provider back to the payer, imagine if these were custom implementation and there are 200 different payers we are building these integrations with. Payer is trying to communicate with thousands of provider practices in the country. It would be a nightmare to do this point to point. And I think that's where using the FHIR standards, the Vinci IGs for PDex, CDex, it has allowed us to build once and just configure and deploy it multiple times. So it literally reduced our implementation timeline from 16 weeks to like 4 weeks, because now we don't have the challenges where you have to undergo dev to dev testing, and you have to again do connectivity from a security certification standpoint. Once these hubs are live, you can now seamlessly connect to multiple data points. And last but not the least, by making this data liberate from silos to being available at the point of care, providers are seeing the value when they treat these members, their patients, at the point of care, where they now see a 360-degree view of the members' data. They are able to see what are the open care gaps or other quality indicators from a payer perspective, which is helping them in manage the right care at the right time in a cost-effective manner. Because if they already see certain things have been done for the member, or a member is overdue for certain things, they can engage it right there and then while the patient is in the room. And this again allows the provider to improve the quality of care, thus improving the quality on the HEDIS or quality on the STAR side, as well as comply with their missed coding diagnosis and other risk adjustment opportunities. That is helping the provider improve the care, the payer get better quality scores, and the intangible outcome is the patient, who at the center of all this is now getting a comprehensive care delivery that would otherwise be more episodic and fragmented in nature. So it really hits the triple aim that is the core for any value-based care arrangement. So with that, let me introduce Ranjan Saxena from Humana, who will further talk about their journey on the Da Vinci side and share some of his lessons learned. Ranjan?
Thank you, Rohit. And thank you everyone for joining this webinar. And I'm glad to be here to share our journey and thoughts on the Da Vinci as a whole, and two specific use cases: payer data exchange, which is PDex, and clinical data exchange, which is CDex. So first of all, like, what is Da Vinci? So Da Vinci is a private sector initiative that addresses the need of the value-based care community by leveraging HL7 FHIR platform. So you can see this big circle here. Ultimately, the value for all of us as a consumer, like, we are at the center of the healthcare ecosystem. Definitely patient outcomes are the most important, but at the same time, the cost effectiveness and for the payers and providers as well. Da Vinci is so Da Vinci, what Da Vinci project contains, or like, is there are many stakeholders, industry leaders, and technology experts who actually get engaged and start discussions. And one of the outcome is the implementation guides for data exchange using the FHIR standard. many type of data exchange. Like for example, it could be related to the gaps in care, it could be related to the risk adjustment, it could be related to the encounter, or many other things. What we are focusing today in this webinar, two use cases, and one of the use cases which I'm going to discuss is the PDex, which is paired data exchange. As Rohit was alluding to, that avoiding point-to-point connection and build some capability which can be reused across the board. So paired data exchange is one of the thing, and you can see here in this picture that is always there, interoperability is always there, but when you see the old standards, or like how we are exchanging traditionally this information, as a pair, we get a lot of information in form of the external different old HL7 standards. We get the ADTs, we get CCDAs, we get the lab results and whatnot, but all these comes into different format. What does FHIR does for the pairs, like, so once we get this particular data, these data streams into different format, we change it to the FHIR standards using Da Vinci implementation guides for the pair data exchange. And then that data is shared with provider at the point of care using like the EMRs, various EMRs or different third-party integrators. So that is what overall pair data exchanges. Now I'm going to talk about the very high-level view of what we have implemented in Humana with our partners, healow. What happens, and this is like 100,000 feet view. What it does is, you can see in this picture that whenever encounter occurs or whenever patient visit to doctor, what they can do is that just on one click they can connect to the Humana. And in the Humana systems, we have this Humana interoperability platform, where we do that conversion of the data into the FHIR standards based on the pair data exchange implementation guide. And you can see that PDex bundle is sent back to the provider, where they can, obviously the data is in FHIR JSON formats. So what we will cover in one of the in the subsequent demo, which we will cover, that you can actually see that this data, how it is presented to the provider in a meaningful way. So that is what the meaningful way, so that they can take the action based on the need of the pair, based on the need of the gaps from an overall care management for the patient's care perspective. With that, I will hand over to Scott from our FloridaBlue. He can talk more about some detail about the architecture around the PDex and CDex. Scott.
Thank you, Ranjan. I appreciate it. Again, I'm Scott Ogden. I'm an IT business architect at FloridaBlue. I've been in the industry for about 19 years, and our team has worked for the past 4 years working to stand up our FHIR capabilities. We have worked currently we're on FHIR R4, standing on a Happy FHIR server. So going to go over kind of what we did, why we did it, a little bit of even how we did it. So give a little bit of transparency into how this implementation worked well for us. So what we did, we implemented the Da Vinci implementation guide for payer data exchange and clinical data exchange. This will allow any subscriber to utilize our clinical decision support service to request a link to our PDex service. That subscriber is then able to gather the clinical data accumulated by a payer across every clinical encounter, as Ranjan was talking about, as well as and retrieve any open gaps in care and coding gaps. So when the clinical visit is concluded, the payer then receives the new clinical information to maintain a current longitudinal record for their members. Subsequently as well, though that clinical data is then sent upwards to the payer so that the payer can as well have that full picture view. All right, so why we did it. By implementing a bidirectional standardized data exchange, health IT systems are able to capitalize on the value of a full picture view of the patient in order to close gaps in care, coding gaps, and increase the quality of patient care, which also supports the clinical decision support lifecycle, the CDS lifecycle. A lot of us have heard that through a lot of the HL7 work groups and the sessions. A lot of seminars on the CDS lifecycle and how it concludes all the way down to quality measures. So standing up these data exchanges, however, between health IT systems without these IGs, the proprietary capabilities expose non-standardized data exchanges. And so this presents challenges in building interoperable channels because of different implementations and data structures. So by implementing a well-known, stable, and standardized implementation with standardized data structures, the solution becomes scalable, as Rohit was saying, to build it once, and then you can deliver it anywhere. So to the next slide, what did we learn? By standardizing the interoperability channel, following the Smart on FHIR security and data exchange pattern, we can easily scale our services to support many clients. Before, this would take multiple connections across various transmission methods and difficult data transformations. So the mapping that we contain is obviously very, very complex. So, but by having a data standard specifically for FHIR, we don't need to perform exhaustive data inspection and mapping to consume or transmit the same information differently multiple times. So if the service satisfies multiple use cases, it becomes even more of a build-it-once solution. So we can move into the next slide, which kind of talks about the how. So this is a summary view of our design, of our architecture from the payer perspective. And this calls out the EMR for healow. So healow, the EMR, has the ability to call our CDS service to perform the bundle request. That passes through the API gateway utilizing OAuth. And the first thing it'll do is it'll return the PDex bundle URL. So then once they have that URL, they can call and get the full FHIR bundle with $ everything to retrieve the FHIR-based API data for that member. Next slide, please. All right, so this here is more of a little bit of a swim lane view. This gives you the little more granular aspect of what we are doing. This gets into the CDS hook, utilizing the patient view CDS hook to trigger the call. It goes through OAuth and returns the token through authentication. And then they will request the FHIR endpoint CDS for PDex. And then it goes all through our system to match on the member, to return the FHIR ID, and then return that patient URL. So we are essentially giving back that patient URL. They can then request with that patient URL the full clinical history. That full clinical history will also contain gaps in care. And then that makes its way all the way back to the provider, or to the EMR, so that they can display those gaps in care, coding gaps, any of the point of care alerts directly to the provider for the patient care. And then this next slide, a couple of questions coming in. For this next slide, it gets a little, it's just more systematic. It's all the same stuff, but this gives you a little bit more of a systematic view, which shows the various actors and the points and times of their calls. I'm not going to go through each of those 14 points, but what you can see here is that we are utilizing OAuth. OAuth is the standard, and passing through our API gateway. We do go through some load balancing to make sure that our multiple server boxes are appropriately utilized evenly. We have our internal gateway as well that maps all of our clinical data for our FHIR server and FHIR repository. And as I mentioned before, we do our individuation and our member match so that we are obviously talking about the right member. But utilizing the the OAuth security module, we will limit our $ everything to apply to the appropriate scopes for security. And on that note, I will be handing it over to Farheen to talk about some of the additional sequencing.
Thank you, Scott. Hello, Alex. Hello, everyone. Good afternoon. My name is Farheen Khalil. I work in the Halo Insights product management team on the interoperability side. We are here to show you not only our engineering and product work within the Vinci project, but also how Vinci enables integrations and use cases aimed at improving payer-provider relationship. So the fact here is that we have two health plans two health plan that we are connecting to is a testament to the Vinci project and FHIR's ability to standardize implementations. I can go ahead and show you some screens that will show you how we have connected with Humana utilizing PDex to deliver Humana's longitudinal record right to the provider's workflow. In the progress note, and we'll close with FloridaBlue utilizing the same architecture to deliver their member summary prior to Halo Insights closing the round trip process with CDex, the exchange of clinical records. So what I see here on the slide is a sequence diagram that I'll be talking very briefly about. We have the provider initiating the CDS hook service to request for the members' data from the payer. So the CDS hook request gets triggered. In response, we'll have the payer returning the $everything URL. And after initiating the $everything operation, we are getting the PDex bundle, which is also called as the FHIR bundle, which has the clinical information for that member, which is going to be displayed onto the provider on the EMR. We also have something called as PDex action response file, which is the information being sent to the payer about specific actions that the provider takes. And we also send the clinical information, which is the CDex bundle, which has the information about the patient's clinical records. We can move on to the next slide, please. So here I'm going to advance a little bit more and show you the request and the response, which happens in the background. We have the CDS service being initiated here. On the left, you can see the request being initiated by the provider. And on my right is the response that we get from the payer. And the payer returns a $everything URL in the response. Can we move on to the next slide, please? Yes. So when the $everything operation is initiated, we can see the PDex FHIR bundle on the right-hand side, which has the clinical summary for the members. Can we move on to the next slide? Okay, here I'm going to show you the demonstration for PDex. Let me share my screen. So on my screen, you're going to see the workflow that I just explained in detail. So you're going to see the Member Insights screen, which has been integrated in the eClinicalWorks EMR. So here the data that you see is from the Humana payer. It's going to be displayed on the Member Insights screen. Member Insights has been integrated in the eClinicalWorks EMR. You can see all the clinical information here for the for the test member. I would like to say here that there is no PHI. We are using the test environment here. There is no real-time information being shown here. This is all test data here that is being shown in the presentation. So similarly, you can also see the same thing being displayed from FloridaBlue. Just excuse me. So in the EHR, what I'm trying to tell you is we are trying to show you that, hey, Humana, hey, FloridaBlue, all this data that we want, the provider is going to request. So the provider is going to request from his chart for the data from the payers, from different payers, from multiple payers, and then that is going to be displayed on the screen. It's all coming underneath the covers, transforming and rendering that into the application. PDex, CDex makes things work seamlessly across multiple payers in the workflow. The provider is going to use this tool in an easy way, regardless of the stuff, all that is happening behind the scenes. Healow, Humana, FloridaBlue, this is conceptually what we describe how, how it works. It just show up on the screen they are used to, and we now know they are not. So looking at some of the data here, we now see that they are not compliant, and the provider is going to know that upfront, and that provider is going to take some of the action to provide that data to the payers for them to take some action. So this is how what we are working with different payers, multiple payers, that is describing the standardization across multiple platforms. So it becomes this transparent, this useful in a snapshot for the provider going to go look, hey, I need to address this, I need to close this gap, I need to do this, I need to order a colonoscopy for the test member. We are now going to go on to the next slide, which is describing the summary and the challenges. And I would like to invite Ranjan from Humana and Scott from FloridaBlue to talk about advantages and challenges that they face during their journey.
Thank you, Farin. Yeah, so as we have spoken earlier, I mean, Rohit, Farheen, Scott, including myself, that it enables, like, specifically the FHIR-based data exchange, whether it's peer data exchange or clinical data exchange or any other things. This allows the standard pattern, a standard way to communicate rather than point-to-point connections, avoids any customization, so that we don't have to deal with multiple code changes for enabling one field, one more, or adding one more field to one particular provider's workflow, right? Some of these advantages are very obvious. The care management at point of care, standard payer data exchange, that's evident. Standard data for EMR workflow, that's one of the, and I think one of the question was being asked in chat, right? Is a payer like Humana is working only with EMR? No, I mean, this standard payer data exchange enables any integration channel, whichever integration channel can be used to get the data to the provider in their workflow at point of care. So that's one of the advantage of these FHIR-based data exchange. One of the thing, and which is very, very important, and we all know that peer-to-peer rule, which is coming and will be effective from 1/1/2026. how to get the other payers' data, right? How to share the data. So some of this payer data exchange implementation guides, which standardize everything, that what needs to be shared, right? Some of these FHIR resources will be leveraged over there. Some of these implementation guides will be leveraged there in that peer-to-peer data exchange as well. So so that's also one of the advantage. Challenges, I'll say yes, the FHIR in general, obviously it's a FHIR, a big JSON. If I'm just sharing the demographic information in a customized, I may have 10 fields, but if I'm using patient resource, obviously it becomes a little bit bigger. And but that's the challenge. That's the challenge. One challenge for and what industry is going through is then changing that behavior, because these kind of challenges are only for short term until we get acquainted with them and we know how to deal with it. There are many tools and utilities which does a lot of this data orchestration needed for the FHIR, or even using the IGs and all. Challenges in converting that's manual mapping is always challenge. Sometime like the version compatibility or backward version compatibility. But as industry is emerging, we are seeing that our implementation guides and some of the other groups like the FAST and others are also working on few of these challenges so that we can adopt FHIR as fast as we can. Scott or Fareen, you can add your thoughts.
Yeah, I'll dive in as well. We're talking about some of the challenges that we've occurred. Again, we've been standing up our FHIR instances for the last 4 years, and getting data across our entire enterprise, which has been established for decades, right? So trying to get that data from the various sources and then accumulating it all together, putting it into a single FHIR server is an obvious challenge. And then on top of it, we're also dealing with data sharing that has, within the last 5 to 10 years, just now being allowed. Whereas everything was very PHI, PII specific, and your data sharing was a big no-no. Now data sharing for value-based care is a great thing. So being able to get the variety of the data across multiple sources into our single instance of our FHIR server through the appropriate maps. And then obviously, when new US CDI versions come out, or R4 or R5, or R6 is even on the horizon, we have to make sure that our server and the data that's associated with it can accommodate it. So, those are some of the challenges we go through, and then in order to create a very clean picture in PDex and CDex, we have to make sure that those data standards are adhered to. Now, by adhering to those data standards, though, on the front end, we remediate a lot of the legwork and the very laborious work that would happen on a non-standard or proprietary design. So again, standardization wins, especially when you're proactive and you build for the future.
Thank you, Scott.
Yeah, we can move on to the next slide and open the floor for the Q&A.
All right, well, thank you for that presentation and demonstration. I'd like to invite the presenters back on screen, as we do have a number of questions that have come in, and I'm going to go ahead and run the list on that today. Okay, so let me do this one. All right, so the first question I think may be for a combination of speakers. So maybe if a couple of you will come on screen from across the organizations, that would be great. The first question is related to Humana. The question is Humana bypassing the provider and working directly with the EMR? Ranjan, you want to take that one?
Yeah, I replied it. So it's not bypassing any provider or any channel, so to say. So the FHIR enables us, or actually enables everyone, right? That you build a connection of an endpoint for the PDex that can be used or leveraged over any channel, whatever is preferred by the provider or provider groups, right? Or whatever is best based on the scenario, which whether it's a big EMR, like if you have to reach out number of providers who are ready to consume that on their EMR workflow. Or if there are mom and pop shop, they say, well, no, I want directly consume it. Just saying, FHIR enables that. So it's not ignoring anything, or we are in this journey, enabling everyone to reuse the PDex anywhere the way it needs to be.
Right. All right, so the next question is, can financial, such as paid allowed amount, components be made available through PDex? The questioner has noted that they know it's not a requirement, but if this is to take the place of value-based care claims, flat files, the financial components would be required. And this would be from a payer to a provider for a given value-based care contract, where the total cost of care, risk, et cetera, are part of the components. So Rohit, do you want to take this question?
Yes, so it's on the financial side. I mean, the PDex FHIR resource bundle, as Scott Ranjan mentioned, can contain various data sets or individual FHIR resources. Coverage is one of them. There could be diagnosis, CPT codes, things like that. From a payer perspective, maybe I'll let Scott or Ranjan add to it. I know many times when it comes to financial, like allowed amounts or other type of NCX12 is usually the claims standards where pre-adjudication, post-adjudication, many of that data sends in. But again, FHIR is, think about it as a container that is shipping data from point A to point B. And again, there can be different FHIR resources that can be constituted within that. But Scott, Ranjan, please add.
Yeah, I'll just jump in. First of all, I'll just throw the caveat for the purpose of this demo today of what we're talking about. We are talking about PDex from a perspective of encounter and point of care, supporting the CDS, the clinical decision support. So, typically when we have that conversation, you don't really talk financial. Does PDex or FHIR support the financial side? Yeah, because you can cover whatever resources that you're opting in with your scopes, especially if you're doing a $sign everything, you're going to get data back. So short answer is yes, it can, but for the purpose of what we're displaying today, we are keeping it limited to the conversation of the CDS, the clinical decision support.
And there definitely, there's a theme here of where there are multiple standards at play, and I'm a firm believer of the and. We've got a number of standards that are obligated for use under HIPAA, but we've also got a lot of opportunity with FHIR to bridge not only to other requirements of standards, but also to really help us free the data and use it more effectively. And so I'm appreciating the general themes that I'm hearing from the presentation and also in your questions, but also want to, understand that, to Scott's point, that we have CDex and PDex doing a particular function at the care delivery point compared to what we might do with administrative data, as they noted, could be shared via X12 transactions or even through FHIR Accelerator Karen Blue Button for the administrative sort of data and other capacities. So there's plenty of standards out there for us to use, and thank goodness we've got a pretty strong set of installs with EDI and using FHIR to bridge to the modern technologies and capabilities that we really want to enable, with everybody being able to, use their phone to get at their data. So we did get a question related to the recording, and I think, Leslie, if you could post that in the chat box, that would be fabulous. I believe it's also on the bottom of the screen that we're displaying. Okay, so I think that next question I want to go to is, what kind of clinical information is contained in the FHIR bundle from the payer? What specific data gaps is that closing on the EMR side? You'd like to start?
Yeah, I can give some, and when we were showing that slide, and it's in the recording as well. So like a lot of, like, for example, gaps in care. That's one of the important thing, right? And gaps in care not only from the HEDIS perspective, but for any need, right? The conditions are that's one thing. The lab results kind of thing, right? So you can say, hey, by the way, you are out of date on this one. Like, can we do that? These are some of the critical. I mean, there are a lot of information sometimes, and Rohit can chime in, sometimes based on the provider, like what kind of provider, say specialist or versus the general physician, and what needs to be shared so that it's more actionable from them. But from a overall data bundle perspective, like we share, yeah, medication, immunization, gaps in care, everything which is clinical in nature.
Rohit, did you want to add to that?
Yeah, no, I think Ranjan covered all the points, so I would put a like button on everything he said.
Okay, awesome. So it's good. All right. So okay. And then let's see. There's just some nice feedback that as a community should continue discussing it currently for value-based care claim level information, often exchanged through flat files and ingested into clinical data warehouses for additional analytics. And this is outside of the X12 process and is extremely important to providers. So if anybody's interested in that topic, Samira Singh would love to have a conversation with you. So at this point, I'm not seeing, let me go to the next, see if there's any other questions we have coming in. We do have a few more. Are the gaps in care transmitted as FHIR resources? The person thought that they saw a CCDA in that section of the patient portal Farheen was showing. So can you, from a healow perspective, talk about how the data is being sent back? Is it a...
Yeah. So traditionally, like such type of interface, I mean, before the advent of FHIR and leveraging the Da Vinci standards for payer data exchange, where payer data is coming to the provider, and then clinical data exchange, which is the CDex, where provider data is now going back to the payer. Yeah, traditionally CCDA was the only gold standard everybody could talk, and good or bad, today many organizations still continue to get data in CCDA format. But now with the advent of Cures Act and MIPS MACRA advancement, everybody, including the payers and EHRs, are now able to communicate in FHIR standards in and out. So we are not just receiving data from the payer in FHIR, but we are also now sending FHIR resource bundle back to the payer. So as a provider, traditional reporting they had to do for documentation they did, diagnosis they included, orders they placed that can help close gaps in care, that information can now be ingested by the payer in FHIR standards too. So these are again using the PDex and the CDex standards respectively. But yeah, the CCDA again is still a supported methodology. Many people still use it for different use cases. So it's surely not replacing, it's more allowing more federation of data that traditionally a CCDA may not allow.
Really good point that it's another and there between the documents and the discrete data, and take us a while to get to the point of high fidelity data really being harnessed and being a major driver. I don't think we're going to move away from documents for a while. So let's talk about a little bit of the feedback that you've received from your incredible journey to leverage CDex and PDex. There's a question about the feedback from the clinicians about the payer data in the chart. Has it resulted in more consistent care gap closures or the other aspects that you might like to share? And I'm going to start with you, Rohit.
Yeah, no, the feedback has been great. We have more than 100,000 clinicians nationwide who are using these tools and technologies today, and every provider we have engaged, they are seeing 90% of engagement rate. And the reason being is it's delivered right within their workflow. there are no disruptions or challenges, because that would otherwise would add to the provider burnout previously, where they would have to access this data. It's not that this data didn't exist before, it's just that it was in fragmented formats, where it would be through a provider portal, they would get it through spreadsheets, they would get it through data pulls that they had. So it was not there at the right place at the right time. And then embedding this within the EHR workflow, this is second in nature, just like all their medical histories and other things. Now they are able to see the 360-degree view of the patient outside the four walls of their clinic. So having this information at their fingertips is a game-changing thing for many providers, where they now are able to see what other conditions the patient was being treated by other specialists or inpatient or outpatient care setting, which again helps them formulate their care in a better manner, eliminate any unnecessary or duplication of tests or orders that they're already seeing from the data coming from the payer, like what medications were already placed, what labs were already done, what care gaps are closed versus still open. So if patient has gotten flu shot as CVS versus patient is still overdue for a pneumococcal vaccine, they can focus on that care. So it's really, the feedback is it's helping providers provide higher quality of care that is directly resulting in better outcomes and quality scores for the provider, better patient satisfaction for the provider, for the patient. And that again is helping, since the patient and provider are doing well, it's also helping the payer in their star ratings and other benchmarks that they measure. So overall, it's a win-win-win scenario for the patient, the provider, and the payer. Scott, Ranjan, anything you want to add to that?
No, you pretty much covered most of it, so I'm good.
Yeah, thank you.
Thank you.
You're also getting strong accolades from the audience who's catching your 100,000 clinician comment about, and really underscores the theme of your presentation today, which is the idea of scalability and reusability and efficiency. So let's take a look at a question for you, Ranjan. Does Humana allow EHR to access any member's data, or does it need to be authorized by the member? I'm assuming this is like patient-generated data that the person is asking about.
When you say EHR, I mean, EHR is just a channel, right? It's basically whatever is allowed by the patient to share with the provider or any clinical or care taker. That's what it is, right? It's not EHR, EMR, or any third-party integrator. They're just the channel. So I would say that it's not for the EMR. I mean, the EMR is the channel, right, to get the data to the provider.
There's a general question that the person is asking around gaps in care and trying to correlate that to a FHIR resource. And they're just sort of trying to figure out how to get from the gaps in care, I think, to what is it in the language of FHIR, or in my view, it's almost like the pieces of FHIR come together and doing a gaps in care sort of information exchange, because we have the data exchange for quality measurement and gaps in care implementation guide, which is another piece of the puzzle. So I'm not sure if this question is really about a resource or more about the which use case to use. So maybe the request can provide input.
If I'm understanding it correctly, and Farheen, keep me honest here, but I believe the context is around how are the gaps in care relayed on the actual bundle itself. What resource are they under? And my understanding is that it's for the clinical data for the measure, and that's how it's consumed from the EMR.
Looks like you got it. All righty. And there's a question about totally co-signing using this or a similar process to exchange claims for attributed patients. So I'm not quite sure how to interpret that one either, because it's, to me, again, we're at the attribution, member attribution use case. But maybe that's not
what is
they're asking.
Can you repeat the question, Alex?
Yeah. Also, totally co-signing using this or a similar process to exchange claims for attributed patients. I think that's sort of out of scope of what you've demonstrated today. So maybe the requester can give us a little bit of more context about that.
Like, just I would add is, like, at least as Scott also indicated, current scope is more on the clinical data exchange. I know with CMS and some of the other payers, they already have claim data feeds or claim data dumps part of the provider organization contracts. Many of those claim data dumps are using ANSI X12 or like 278, 275 type of transactions, but at least like we have not explored using PDex or CDex for claims data dump. I mean, CMS themselves uses a CCLF file format, which is again neither FHIR nor X12, but again, those can be where people can take these containers and be able to explore what FHIR resources you can surely, you have the capability to put ICD, CPT, procedure resources. So all those FHIR resource bundles allow you to translate that information to.
Thank you, Rohit. That brings us to the conclusion of the audience questions that we've received today. So with that, I think I'm going to say thank you very much to everybody. Thank you for the robust question set and your participation in today's event. The recording and the program update slides will be posted tomorrow morning, and we welcome you to our June 28th roundtable, the next session that we'll be holding. And with that, everybody have a wonderful day.